Hey everyone, thanks for tuning in today. We have a really special episode for you waiting, so I just want to hop on. I appreciate you guys all taking the time to listen to the Gestalt Education podcast. Brett and I are truly humbled by all the positive feedback and things you guys have said, and so as always, we really appreciate each and every one of you. Buckle up. This is kind of a longer episode, so we kind of apologize for that. However, it was really important for us to dive into some of the things that Dr. Mumma really had to talk about, and we think it's a really important topic and something that we can all always get a little bit better at. And so have fun and enjoy the show.
We'll keep going.
I'm on my way to run.
All right, guys. Well, with that being said, welcome to our newest episode of the Gestalt Education Show. I'm Dr. Taylor Premer, along with my co-host, Dr. Brett Winchester. Today, we are lucky to be sitting down with Dr. Lindsay Mumma. So, Dr. Mumma is the owner of Triangle Chiropractic and Rehab in Raleigh, North Carolina. She also has a special niche for being a female health expert, all the way from the start of pregnancy to the end and after. And we're really excited to be here in St. Louis with her teaching the MPI Full Spine Seminar. So tonight we just got done with a great dinner, and we're having a little bottle of Shea Wine Cellars, all the way from Willamette Valley in Oregon. It's the 2016 estate. It's beautiful. So Brett and I have been lucky enough to be there at the vineyard and check it out, and it's a gorgeous spot. So anyway, with that being said, Dr. Mumma, we're really lucky to be sitting down with you today. So let's kind of start with your niche with female health. Where did it all begin? How did it start in your community, and kind of where are you at now? We'll put it that way.
Well, so now I'm in a very different place than where I started, because I did not start in women's health. I mean, I think I probably drew more of a female population, but it's, statistically speaking, more females see chiropractors than males do. So that was kind of already working in my favor, I guess, in that way. But I intended to have a functional model practice. I wanted to see athletes. I figured that I would see, my patients who got pregnant, but I didn't intend to see pregnant patients. And I took care of some of them kind of as I thought I would. And then my husband and I decided to get pregnant, and I realized I really did not know nearly enough about pregnancy to feel like I was going to be making an informed decision. I was like, okay, I know the basics here, like the birds and the bees, but I don't really have any more information about what being pregnant is going to be like, and what's that going to be like for me as a doc, and what's it going to be like for me as an athlete, and what's it going to be like for me in the postpartum period. And so I kind of did a little bit of a deep dive, and just as I was learning things, having conversations with patients, and then having conversations with friends or colleagues or whoever, they would say, oh, well, Lindsay is looking into that, or Dr. Mumma is, checking that stuff out. And so it kind of started spreading a little bit more. So as I started looking into pregnancy more, I started to just see more pregnant patients, which then gave me more experience in seeing pregnant patients. And then, I got pregnant, and that experience taught me a lot about pregnancy. And again, helped me fill in the gaps of what I didn't know. So I'd already gotten a doctorate, and I did intentional planning for getting pregnant, and I still felt like there's so much that I didn't know. And so I just kept diving, essentially. I was like, okay, well, I need to know more about the female cycle, and I need to know more about pelvic floor function, and realized, okay, well, all of this rehab stuff that I've done has set me up for recognizing core and pelvic floor dysfunction, and the time that it shows up the most is during pregnancy and in postpartum. And so I felt pretty equipped from a biomechanical standpoint to continue to help patients in that way. But I just felt like there was so much about pregnancy. I've been a woman my whole life. How do I not know more about this stuff? And so as I kept learning, it brings more people in the door, and then those people coming in the door bring more people in the door. And now I mean probably 60 to 70% of my patients are pregnant or postpartum. And that's kind of, and then I see their families and friends and loved ones and things like that. And then, we still get the, high school athlete with knee pain, and the, CrossFitter with shoulder pain, and the weekend warrior, and somebody who's got low back pain from work. But it's a lot of prenatal and postpartum care. So it's completely different than what I thought I was going to be doing. When I graduated from Palmer, I had like just under 600 continuing ed hours. I was like at a seminar every weekend. I was like trying to hang out with Brett as much as I possibly could. And I had like 2 courses in pregnancy. That was it. The rest of it was like all rehab, and so it's not at all what I thought I was going to be doing.
What's the biggest misconception with treating the pregnant patient? Like what are the things that kind of shocked you, I guess, that might be different than what our listeners, other people might think?
Well, I think a lot of people, like there are some patients who come to me, they're like, well, my chiropractor doesn't see pregnant patients. And like, what a disservice, I think. I think during school, we tended to get a little bit scared of treating the pregnant patient as like from essentially like a liability standpoint, you know, which I mean, there's merit to being cautious, but I think that it's really doing a disservice to patients who are in the most, like the diversity of the biomechanical changes that happen during pregnancy and in the first postpartum year are the only other time when you see that much change is in the first year of life. And so for chiropractors to not be part of that, I think is a huge mistake. So I think people think that pregnant patients are like, you need to be more cautious. Well, you need to pay attention, but if you're really good at palpating and adjusting, you're not going to adjust a hypermobile SI joint on a pregnant patient because it's hypermobile. You don't need to adjust it. And so I think there's a lot of like, oh, well, you know, and you're not even going to find restrictions in them because they're so hypermobile because of all the relaxin. I definitely am finding things that need to be adjusted on my pregnant patients. And, you know, and I also think that there's, as a society, like not even in the manual therapy world, I think as a society, we tend to have a complete backwards view where we want pregnant people to, like, we're going to take care of you and we're going to go above and beyond and oh, do you want me to carry that for you? And then the postpartum time period, we're like, okay, well, you ready to go back to the gym and like get in your jeans again? Like, it's just, it's a complete bullshit way of looking at what's happening because hormonally speaking, prenatally, you're like a freaking superhero. Like, you have enough within you to keep at least 2 humans alive with just your own body.
Right.
Like, that's pretty amazing. And then in the postpartum time period, your entire core has been completely rocked. You brought another person into the world. Like, all of your tissues were stretched to max capacity, and or you had major abdominal surgery on the same day that you gave birth to a human, and now you're figuring out how to feed said human with your body, or trying to figure out how to feed said human when you can't use your body to do it. Like, there's so many different things about the way that we look at it where we're like, oh, this, you know, like, really coddling the pregnant woman, and then in the postpartum period, like, expecting her to bounce back. And I hate that terminology, and I hate that that's the way that we treat people. And so I really kind of work to educate my patients on, like, enjoy the, like, extra attention that you're getting when you're pregnant, for sure. Like, if somebody wants to get the door for you, absolutely. But like, in the postpartum period, you have to ask for that because people aren't really willing to go above and beyond to kind of like help you land, and encouraging them to slow down the postpartum time period because, you know, cognitively speaking, after giving birth, like, you have the ability to walk, but you don't have the core stability to hold yourself upright. And so, like, slowing down the postpartum time period is something that, like, I feel like that's a huge misconception that, you know, 5 minutes ago when you asked me a question, like what we need to, like, revert. But that's one of those things that, like, I'm completely changing the way that, you know, a patient walks in and they're like, okay, well, you know, I don't know if maybe I should be lifting because I'm pregnant. And I'm like, well, strength training is an absolute part of creating a more robust musculoskeletal system that is going to help you through pregnancy, in the laboring process, and in the postpartum time period. And then in the postpartum time period, do not go to the gym at 6 weeks. Like, you have no business running when you're peeing your pants. Right. You know, and so a lot of what I think we get...
Oh, so they get it kind of backwards.
Oh, 100%. Yeah. And I think we get, as a society, I think we get kind of miseducated about that. Right. And I think a lot of it is just because, you know, historically speaking, like, y'all haven't been in birth. Right. But, like, the first time that I saw somebody breastfeed was when I was planning to give birth. You know, like, I never saw anybody nursing. So, like, I didn't know what that experience was gonna be like. And there's so much really, really amazing reflex stimulation that happens with nursing. Like the breast crawl, when babies are born, they cannot crawl yet, but they will breast crawl. And it's all of their infant motor reflexes that allow them to get there. And so like seeing that stuff take place and knowing like, wow, I have tools to like help facilitate this. That's amazing.
Yeah,
you know?
Absolutely. Well, we always say too, like our pregnant population is so underserved because the Western med community really doesn't have an answer for them.
Right.
Musculoskeletal pain, dysfunction. I mean, it's not like you can just pop ibuprofen your whole pregnancy for your low back pain.
You would be surprised at how many of them are getting that advice from their OBs though. Where they're like, okay, well, you know, we could put you on a low dose of codeine. Excuse me?
Right.
And you know, a lot of them are taking Tylenol, but there's been research about how negatively that affects the fetus.
Sure.
And we're still doing it. And so if you can, like, you know, getting connected to midwives and OBs, that's been huge because they want to help their patients, but they don't have any tools to be able to do that.
Right.
So if they're like, oh yeah, you know, I have an OB practice that refers me a lot of patients, and the one OB knows me, and the rest of them just say, oh yeah, Dr. Nguyen knows somebody. And so they all through her refer to me because they want to help their patients. They don't want pregnant women walking around in pain all day. You know, and I don't think they feel good when they say, well, it'll go away when the baby gets here.
Sure.
You know, I think they're trying to maybe be encouraging about it, but it probably doesn't feel good. Like, oh, well, if you wait 6 months, it'll go away.
And it doesn't. The research on it's fascinating that 50% of women who had low back pain during pregnancy, they still have back pain 1 year after childbirth. So the thought that, oh, once you have the baby, your back pain goes away, actually that's not right.
It's A, not true, and B, it's just kind of rude.
Right.
It's just like, oh, well, suck it up, buttercup.
Yeah. Like, fingers crossed things are going to get better.
Yeah, exactly. But if you think about it biomechanically, you know, the gross motor changes that happen during pregnancy, well, so you have these huge adaptations that occur over 40 plus weeks of being pregnant. And like the rib cage widens by as much as 7 inches. That's huge change, right? And then you think about what impact that has on the diaphragm, and then we're changing the juxtaposition of like where the core is. And so you've got this ginormous expansion that's happening. All of the biomechanical changes that are happening are destabilizing the core. So then in the postpartum time period, six weeks postpartum, you got a green light. Go ahead, have sex, go run, do whatever you want to, you're good to go. You have absolutely no core stabilization. You haven't rebuilt that. So then of course, a year postpartum, you're gonna have low back pain still because your core was destabilized and then you just added load to it. Right. That's not really a recipe for success.
And that's not even talking about the females that don't have low back pain but still have incontinence, they have leaking, they have things like that are still in that same picture. And so we had a conversation before we left for dinner about that you have a pelvic PT with you now. And so how does that then route the postpartum female look in your practice, or how does that population need to be served better, or you know, maybe expand on that a little bit?
Well, so technically, I mean, I don't know when this gets released, but she's not in my office yet. She's coming.
Sure. Okay.
This month is when she's coming.
Jinxed.
God bless it.
We'll wait.
She gone.
But I mean, it's not going to change anything other than instead of referring her out, I'm going to refer her down the hall.
Yeah.
Let
me reword that question if you don't mind. So who are you not getting better that she will get better?
That is not at all what I do with my pelvic PT referrals, actually. That definitely is something that I will refer to if I'm not seeing the type of results that I want to get, but I refer all of my postpartum patients to pelvic PT.
That's interesting.
It's cool.
Like across the board, I think, like in my perfect world, all pregnancy would see a chiropractor and a pelvic PT during their pregnancy. So a lot of pelvic PTs will not do internal work during pregnancy, which like may or may not be indicated. If it's indicated, I think that's, you know, it's up to the PT and whatever malpractice insurance they have, if that's something that they're going to do.
Yeah.
But even just like breaking down the barrier of, I don't need this resource yet, and I'm going to meet you and I'm going to look you in the eyes and I'm going to see who you are. I'm going to establish a relationship with you. So that in the postpartum time period, when I'm sleep deprived, when I'm trying to figure out nursing and what the heck, I'm peeing my pants, now there's not one more barrier to entry of like, I have to go meet who, you know? And so I would love it if they saw a pelvic PT during their pregnancy, and then for all of the aforementioned reasons, see a chiropractor during their pregnancy. And I think that in the postpartum time period, chiropractic and pelvic PT they would just make a huge difference. And so
this
it's
pelvic PT, is that just insinuating internal work, or she's doing other things besides that?
So ideally internal work. I'm not doing any internal assessment, sure. And there are a lot of injuries that happen within the pelvic floor. Like even, so I will talk to patients about this. It doesn't matter if you have like this beautiful, serene birth, like by a creek, and you've got a baby deer as your midwife, and like there's a squirrel for your doula, and like you're just like chilling, and then you have this lotus birth, and your placenta's attached for like 3 days, and like everything is super zen. Like you still had a traumatic experience of a baby coming out of your vagina. And so like it's a huge tissue inflammatory response that's going to happen. You're going to get the same recommendation at 6 weeks as someone who had a planned vaginal birth, labored for 24 hours, and then had an emergency C-section. 6 weeks, good to go.
Yeah.
Right? So there's so much completely unknown about the internal tissues that I think it's a really good idea to have an internal assessment. Now, a lot of people aren't going to take me up on that. I'm still going to refer them.
Sure.
And then it also just kind of opens up the conversation of maybe you don't tell your chiropractor that you're peeing your pants. But when your chiropractor brings up that I recommend that all of my postpartum patients go and see a pelvic PT, that brings in more conversation about what is to be expected, because they've been hearing for years about how, oh, well, after you have kids, you just cross your legs every time you sneeze. And so
right.
we get conditioned into thinking like, oh, this is just a normal part of having kids. Well, there's nothing normal about not being able to hold your bladder. Once you've been potty trained, that's no longer a normal thing, right?
Yeah,
and, it's a serious problem in our society. Apparently, about 40% of people who go into a nursing home go there because of incontinence.
Wow.
So like, if you cannot handle your bladder, that's gonna crap out on you in a literal and figurative way. It's gonna crap out at some point, and then you're gonna be needing to be in assisted living for that. Like that's a huge quality of life issue. You think it's no big deal. It's just, well, it's just if my bladder's full and then I sneeze, or if I laugh, or if I run, or if, okay, let's investigate why that is, And maybe it's simply a respiratory issue. Breathing changes significantly during pregnancy. I reteach my patients, even if they've been patients of mine way before ever deciding that they were going to conceive, and they're like excellent breathers. In the postpartum time period, they might as well be infants. We're going to start from the beginning, and I'm going to reteach you how to breathe, because your whole body just went through like a giant reset. And what an opportunity, right? Like you think about athletes who take a time, like they get injured or they get sick or something like that, and they actually decide then that they're going to rehab that thing that they've left alone for a while. Like what an opportunity. Postpartum is a great opportunity to reset some of your motor patterns and like give you a new clean slate to start from.
Yeah, wow, that was awesome. And then from that idea, I guess, then what's the transition look like for your patients that maybe were in the gym that at that 6 week mark, maybe they're ready to start working out and stuff? What's the education like for them to start that transition?
It's basically just like a slow your roll kind of conversation.
Yeah.
There's such a mental outlet for people to be able to go to the gym, and also like there's community there, especially like in those kind of like small boutique fitness like CrossFit gyms and things like that, where like this is my community. They're at the gym, and I want to go to the gym, and I feel good when I work out, and I'm really tired, and I'm stressed to like infinite amounts right now, and I don't really know what's going on, and I don't know which way is up, and the one thing that feels normal is to go to the gym.
Sure.
Well, if you can't stand on one leg without having your, pelvis cave, and like you're not able to have any stability, then what business do you have putting load on that?
Right. Doing like 50 overhead snatches or doing.
Yes, exactly. And so like the conversation that I have, ideally that's happening during my prenatal visits. Like, and the world is not perfect, and I see plenty of people who are like 4 months postpartum, and they're like, my knees are killing me, and I've got this like aching low back pain, and oh yeah, on your questionnaire you asked me if I pee myself. I mean, yeah, but like doesn't every mom, And so that is a harder conversation than the 6 week conversation, because the 6 week conversation, if I can talk to you about why it's not appropriate to go for a run right now, and how I can help you set up a foundation to be able to go for a run when it is appropriate. But I don't recommend that any of my patients before 3 months postpartum are running. And just because you've met the 3-month mark doesn't mean that it's appropriate to start running now. Like if you have no base of stability, it doesn't make any sense to run. So many of my patients love to run. I want to get you back out there as much as you want to be out there. I just want to get you out there in a way that allows you to continue running. I want you to have a long career of running for however long you want to when you're ready. So if I get them at that 6-week mark and we're talking about like, okay, so you're ready to start activity, great. I have a postpartum rehab class. And it slows them the hell down. Like they think that they're signing up for like, okay, yeah, we're gonna like grind, we're gonna get after
boot camp, and it's like, yeah,
okay, you're gonna lay down for 5 minutes and breathe with your diaphragm, and like, you know, and there are so many emotional things that happen with birth that a lot of people. So like, first time moms, like they're like no longer a maiden. Like there's like this huge archetypical change that happens where they're like, oh shit, I'm a mom now, and like this is a different, like I'm a new person. This is a completely different person than who I was before I gave birth and like before I got pregnant, like and all of those changes. And so like spending time breathing allows them to kind of visit those thoughts in a way that they haven't before. And so like there are just huge changes that happen that aren't just biomechanical. They're not just physiological changes, and we need to allow space for that to sort of unfold. So I have a 6-week postpartum rehab class. It is not a 6-week like get your body back, any sort of that nonsense crap. It's literally 6 weeks of like, let's set a foundation. Let's do some DNS movements. Let's figure out how to actually breathe. Let's figure out what it means to mobilize your TL junction, which is where they put an epidural. So now you've got scar tissue at your posterior diaphragm. Well, that's not going to work out very well. And so many people don't realize that they have aberrant sensation right over the epidural site until I palpate it. I'm like, can you feel this? They're like, oh, that feels weird. Like the official term is that they get the heebie-jeebies. But so, you know, like having them work through some scar tissue mobilization. And if they've had an abdominal surgery, a major abdominal surgery that doesn't come with any post-op PT. What?
Yeah.
On the day that they give birth. Like it's wild. So for babies who come out the sunroof, you know, we're working on some abdominal massage and, but like some women are not ready to touch their scar.
Right.
Like they can't, they don't want to look at it. They don't want to touch it.
Yeah.
So we're just going to give them a little bit of time. We're going to breathe. We're going to breathe into it. When you're ready, we can touch it. It's a slowdown. So
yeah.
What's the continuum of care? Let's just say there's no like acute episodes of any pain syndromes during pregnancy. So do you recommend like you like to follow up with these patients? You know, how often do you not follow up with them? What's the plan? And then after the birth, then when do you follow up postpartum? Like what's kind of your typical for the people that are not necessarily in pain?
Yeah, so if you're having an asymptomatic pregnancy, I'd love to see you twice in the first trimester, right? So that a trimester, for listeners who are not aware, 12-ish weeks, okay? So I'm gonna see you once every 6 weeks is what that looks like, right? Like let's check in. Your squat at 6 weeks is going to be different than your squat at 12 weeks,
right? Because
your biomechanics are changing so rapidly. And so if you're just continuing to do what it is that you're doing at the gym, I want to know what that looks like because that's changing. Weeks. So then in the second trimester, probably once a month. Weeks 25 to 32 is typically when baby gets into the vertex position. And so it is outside of my scope of practice to palpate a baby's position. So I ask them to ask their provider baby's position, and providers do not typically tell baby's position unless the patient asks. Until like 36 weeks usually. And so I ask them to ask their provider because that is typically when baby gets into their position is like between 25 and 32 weeks. And so during that time, if we don't know baby's position, I might see them a little bit more frequently just to make sure that everything's balanced. We want to make, and so I'll kind of like draw their attention to what they may be doing that's completely asymmetrical in their activity. So like me personally, I always adjust thoracics from the left side of the table. During my pregnancy, I also adjusted from the right side of the table, just to like prevent myself from having way too much tone on one side as opposed to another. And like when I would do split jerks, I would alternate legs, which feels super weird until like I literally don't remember what my dominant leg was because I did so much like opposition training.
It's a good little goal.
Are you bragging now?
No, but like I don't
brag.
split jerk as much as I used to. Okay, thank you for the pat on the back. But like I want to know what they're doing in their daily lives that might create a little bit of asymmetry in their body, because asymmetry in the body includes what's happening within the uterus.
Sure.
So if you're always like leaning to your right, well then baby's going to move to the left, just because like it's a real estate issue now. And so you know, I may see them a little bit more between 25 to 32 weeks, and then 32 to 40 plus. Just a side note, babies are not late if they're not born after, like if they're not born at 40 weeks, they're not late. They are technically not, they're not past their due date until they're over 42 weeks pregnant. And everybody is so used to that 40 week, like it's like a library book, like it's overdue now. You have to check out, right? But so between 32 and 42 weeks, it kind of varies depending on what's going on, but I would recommend once every 3 weeks to 36 to 42 weeks, I say usually once a week.
Nice.
And then the postpartum time period, if they're feeling great, I tell them to make their first outing to come and see me at 2 weeks postpartum.
2 weeks.
If they're not feeling great, if baby's latch isn't great, if they're having any issues with feeding, I will do a home visit if they want me to. And if it's reasonable, I mean, like I have some patients who travel from really far and I'm not going to go do a home visit for them as much as I love them. But they can come in before that. I just, you know, like stay at home, don't put any clothes on, be naked with your baby, let them do the breast crawl, you know, and like kind of figure out your family dynamic,
right.
Like introduce your dog to your baby and all of that. Like right. you don't need to go anywhere.
The important stuff.
Right. Yeah. Now, if you're having issues, like please call me.
Sure.
But I recommend that they make their first outing at 2 weeks postpartum, and then we just go from there. Yeah. You know, like if at 2 weeks postpartum they've got, you know, they had an epidural and so we're working on scar tissue mobilization, or if they had a C-section, then it's going to be a little bit more it's going to be more intense by being slower rehab. You know, they have more healing to do. And you know, that's a post-op patient and a postpartum patient. And so there's a bit more rehab that goes into that. And then, you know, ideally I get them into a postpartum rehab course. If they don't want to do it, I'm like, that's fine. You're just going to pay me more because we're going to do the things in person as opposed to you doing them on your own. So
yeah, that's awesome.
Who are the icons of the people that you've really looked up to in women's health? Like who are, I probably have a pretty good idea of like as far as like manipulation, DNS, etc. So, but in women's health, like who are the names? What are the textbooks? Like where did you educate yourself on everything that you know?
I really wish that there was like a concise answer to this, because like the way that MPI is such a gateway for recognizing other modalities that can be helpful. Like I wish that existed for a functional birth model, because like, so deep dive here if you want to just like start listing off some things. So Tony Weschler wrote a book called Taking Charge of Your Fertility, which like I would recommend for any person. So regardless of if you want to get pregnant, just figuring out the fluctuations of the female cycle. I didn't know that stuff until I wanted to get pregnant. You know, like I knew that I couldn't get pregnant the whole month, but I was supposed to take birth control every day. And that didn't make sense to me, but I didn't really understand like what all changes were happening within my body, and like recognizing that there are like cervical positioning changes and like cervical mucus changes that happen. I think that's valuable information for a healthcare provider to have, because it's there's a book called The Fifth Vital Sign, and it's literally talking about like your cervical health is actually like one of your vitals that lets you know what's going on. Dr. Christiane Northrup, she wrote the book Women's Bodies, Women's Wisdom, and she's kind of like a pioneer. She's like a functional OB before that was at all a thing. She's kind of an OG, but she was on like Oprah's top 10 book list, you know, and I don't know, not enough people know about her. She's kind of awesome. Elisa Vitti has done a lot of, she wrote the book WomanCode and In the Flow. Those are two of her books, and she talks a little bit about like that cyclical health type of thing. So those three are kind of like female cycle. Tony Weschler, Christiane Northrup, and Elisa Vitti. And then in terms of like childbirth stuff, May Gaskin is amazing. She's like the grandmother of modern midwifery. She's incredible. They have the farm in Tennessee where they have a 4% transfer rate. So if you go to the farm, it's like having a home birth, but you're like living on this commune, because that's like, she was a hippie and she attended the births of the hippies who were moving across the country. And like they just kind of screen their patients. And if you are a good candidate for a home birth, their transfer rate to the hospital is 4%. That doesn't mean that 4% of those patients are getting a C-section. Like our C-section rate is about a third.
Right.
4% of those patients are even transferring to the hospital. And the number one reason for transfer to a hospital from a home birth is exhaustion. So it's just to give mom like some meds so that she can rest or whatever. But May Gaskin, and she has several books. Penny Simkin, she's actually a PT. She has some really good information. In the chiropractic world, Jeanne Ohm, who passed away last year, oh my goodness, 2 years ago, I guess. She really did a lot for awareness. Yeah, for sure. And like Webster it's a great assessment. It's an assessment that I use. I trust my hands more than I trust a protocol-driven approach, but it's really wonderful. And like my patients have no idea what Webster is, but they know that they're supposed to see a Webster certified chiropractor when they're pregnant, because their cousin told them or whatever. And so she did a lot of great things for awareness of chiropractic and pregnancy, I think. So that was helpful, and I learned some things from her. And I don't know, I just, I read a lot of like Lil HA League things and like breastfeeding, and I gotta remember who wrote it, but I send it to all of my patients. There's an online magazine, it's called Mothering, and it talks about all of the reflex stimulation and the breast crawl, and how laid back nursing is the biologically appropriate way to feed your baby, because we get taught how to breastfeed the way that people teach you how to bottle feed. So laid back nursing actually allows for babies' reflex patterns to play out to allow them to nurse more efficiently, which is pretty freaking cool.
That's amazing.
Yeah. I mean, it's really been like kind of a process of discovery, and then just like talking to midwives, talking to OBs, talking to doulas. Dr. Erica Boland, honestly, is like a freaking pioneer in all of this stuff. She was so Erica is one of my best friends, and
she was an MPI rep.
She was an MPI rep,
yeah,
and she is currently in midwifery school. She's just a freaking badass. And she's a doula, and so I called her. I was like, hey, I peed on a stick yesterday, and I'm supposed to test my 1 rep max back squat today. Like, what are your thoughts on that? Because at the time she had 3 kids, and I was just like, what do we think about this? And so she was really excited. It was my first pregnancy, but there was like not enough guidance on what being athletic during pregnancy looked like, and there's been an absolute explosion of it in the past couple of years. And I think social media has been really helpful for that, because like people at my gym were posting pictures of me in 2012 working out, and like a whole bunch of people commenting like, oh my God, is that safe? Like, what did you think I was doing like 1,000 years ago? Was I just like sitting in a cave? But one of the things about there being this kind of explosion of information about working out during pregnancy is that a lot of it is just bogus. Like a lot of, and we don't have great research on pregnancy, because it's not really super ethical to be like, well, why don't you try it? Why don't you not? Let's see who doesn't die. Like that's not really a great approach.
So what are the no-goes for exercise during pregnancy? I mean, so what are the things that because I remember seeing the videos, and they were awesome. So what are the things that you, for example, wouldn't recommend, or are there any guidelines? Or?
So actually 2012, there was a book that came out by James Clapp and Marissa Cram, I think. I always say James Clapp, and then I forget the et al. People. clap at all. But the book's called Exercising Through Your Pregnancy. It's got like the cheesiest cover. It's like a woman in a velour suit, like fake running. Anyway, but the book is freaking gold. Like, redo the cover, but the book is absolute gold because it actually goes over contraindications. So like, if there's bleeding and we don't know the source of it, absolutely do not work out because we don't know what's going on. So we're going to figure out what's going on. Now, if there's bleeding and we actually have, like, we know it's not like a hemorrhage of some sort, like it actually is possible that you can work out. So what he did was study. It was like 2,500 or something. So like decent study size, not huge, but it was people who were already choosing to work out and people who were choosing not to. And so he was like, okay, we're going to follow what they're doing. And like no increased risk of starting a new exercise regimen. So many people think that you can just keep doing what you were doing. Well, what if what you were doing was like rope climbs or skydiving? Like what if that was your exercise regimen? Like should you keep doing that? You know, like you kind of have to think about like what is your, like how are you going to mitigate risk here? Well, I'm probably not going to climb to the top of the rope. You know, I'm not going to skydive. I don't feel comfortable doing that when I'm pregnant.
Or if you're a climber, if you're a
I mean, you kind of have to think about like what those things are. He found that there was absolutely no increased risk to mother or baby if they started a new exercise regimen during pregnancy, which is a freaking game changer.
It is.
Because so many women have been told like, oh, well, just keep doing what you're doing. Well, they're in their second trimester and they're like, well, I meant to start running and then I found out I got pregnant and then I got super sick and now I can't do anything for the rest of my pregnancy. Well, you're about to run a marathon. And you've got a 40-week training period during which you can prepare for a marathon or you can sit on your couch. Right? My first labor, start to finish, was 40 hours.
Oh my God.
Okay? I did a half Ironman. That's like my biggest, like claim to fame of like activities that I've done. It was 6.5 hours. I'm totally bragging. But it was 6.5 hours. Like, done.
That was nothing.
Right? It was nothing. I thought that was like a very large athletic endeavor. No, it wasn't. So to not prepare physically for that is asinine to me. Yeah. Because and the other thing
that's
is,
a good way to think about it. I've actually never.
Yeah, no, it's really good because I mean, there's OBs in our area that say that. Well, as long as you're exercising now, keep going. But if you're not, don't do it.
Yeah, send them a copy of the stupid cover, but maybe an e-copy.
There you go. Yeah,
I got you this on Kindle. But there's no risk to starting that. The things that I say are just kind of a common sense approach of like, okay, are we going to be doing a bunch of sagittal plane flexion exercises? No, because at the end of pregnancy, 100% of pregnant patients have a diastasis of the rectus abdominis muscle bellies. So what do we need to train? Not flexion. Right? Yeah. We've got the rectus abdominis muscles are literally not in the same position that they were prior to pregnancy, nor in the same position that they will be in the postpartum time period. So why do we need to train what we use those muscles the most for? So, because oftentimes people will be like, oh, okay, well, I can't do toes to bar, so I'll just do knees to elbow. It's not about the range of motion. It's about the actual mechanics of the movement.
That's such a CrossFit.
It's so good. Seriously. And I mean, okay, I did full toes to bar in my first pregnancy because I was like, I can rehab this postpartum.
What's the worst that can happen?
The worst that can happen. I was such an idiot. But I was just like, I can do anything. And, it was like helpful that people were like, oh my God, you just kicked my ass in that workout. And I can't even believe you're pregnant. But I was like, yeah, I feel amazing. Yeah. So I really needed somebody to just smack me in the face and be like, Lindsay, slow down, you're growing a human. But I felt amazing. Like I accidentally PR'd my back squat when I was pregnant. I was like, oh, whoops. Yeah. I wasn't trying to do that, but I just felt really good. I didn't realize that I had put on more weight. I just add a little bit of weight. That feels good. Add a little bit more weight. Then the postpartum time period, oh, no, I really do need to slow down.
Yeah. Well, I think in you're a good example of you're a healthy individual. So, I mean, not all pregnancies are like that or like that pregnancy period. And so kind of what you talked about earlier, just being there for your patients to support them through those times. So maybe they do have difficulties. Maybe they are going crazy and holy shit, I feel amazing. To be able to give them a pep talk. I think that was a really good transition point of being there for your patients, meeting them where they're at, and then having them, if you don't have the answers, you having people in your stable that do have the answers, or having resources for them and stuff like that.
Yeah,
so,
I don't know everything. That is for freaking sure.
Yeah.
I'm asking questions all the time,
Yeah.
you know? And like my second pregnancy, I was probably more healthy than I was in my first pregnancy. And I was like getting migraines and I was just like lethargic and like my arms got fat. I was like, what is happening? Like what this is a completely different experience. And like I was very grateful for that experience because I was expecting it to be more like my first. My second pregnancy was just so much harder. Like I was still working out. Like I was doing like 3 to 4 days a week probably, but I was like, okay, I'm gonna be smart about my workouts. And then I was like, maybe I need to kick it up a notch. Why are my arms fat? Like, what's going on here? But so I was actually convinced that my second was a girl because I was like, this is such a different pregnancy. But every single pregnancy is different. And so that's what, like, I continue to be able to learn from my patients because even though I know that their next experience is going to be different, when they come in and they tell me about like how it's different, then that's just like more information for me to figure out like, oh, okay, so in your last pregnancy this was possible and this was fine, and in this pregnancy it's a little bit different. But that's the other thing too, like general rules of thumb when you were talking about like, you know, exercise that you can or cannot do. My friend Mel says that you know, exercise during your pregnancy is kind of like you have to have the mentality of like the ability to do something is not necessarily the license to do it, because like you have the ability to put a fork in a microwave. It doesn't mean it's a good idea. So like just because you can do something doesn't mean that you have to do something. And so being aware of like what your body's response is. So like running during my first pregnancy felt great. Like all the way through the third trimester, I felt totally fine to run. I had no discomfort, no pelvic floor issues. I felt fantastic running. In my second trimester of my second pregnancy, I was like, well, that's out. I just feel like crap when I run. Like that's no longer a comfortable exercise for me to do. And it's not because biomechanically speaking, there was anything wrong with it. It just no longer felt like a good activity. And so one of the other things is just like helping patients figure out how to be able to listen to their body, because they get told that a lot. Like, oh, well, just listen to your body and you'll know what to do. But they have never spent any time at all like associating into their body, and like they can't feel themselves to get the feedback to know, right? And so just like asking more questions about like, well, how did you feel when you did that? How did you feel immediately after? How did you feel later in the day? Like opening them up to like different times and places where they can kind of check in and find out, oh yeah, you know what? I did actually feel worse later in the day after I ran. Well, that's interesting. I felt fine to run. But then, and now this is a pattern. Every time I run by 4 p.m., I feel like crap. Good to know.
Well, I think that this is like we're a little bit over on our time than what we usually do, but but it's important to know because I mean it's interesting for me for sure, because I think you gave some really good insights for, obviously I'm not a female, I don't have the ability to carry a human being inside me, and so sometimes it's difficult to meet my pregnant patients where they're at, but I think you gave some really good tools for me for sure to take away to meet those patients where they're at and to better understand kind of what they're going through. So me personally, I thank you for that. But
my pleasure.
So Lindsay, so if our listeners want to contact you, maybe they want to shout at you, do stuff like that. We understand, we found out tonight you work off a flip phone, so we understand text messages probably aren't the best. I don't know, do you have to pay, is it 99 cents a text message or like?
Texting is great. However, I'm not giving out my cell phone number because I have freaking boundaries.
So what's the best way to get a hold of you to learn more information? Yeah, exactly. to get a hold of you to ask more questions, or besides following you on the MPI circuit and stuff like that?
Two things. First, I do want to say this is what you said about being a male and like not being able to, like having a difficult time meeting your patients there. The majority of OBs are males. So like any male practitioners that I talk to, like I'm just going to remind you of that. They have no problem meeting their female patients in a birthing situation. You can absolutely work with female pregnant postpartum patients and like do a wonderful job. If you're able to hold space and you're able to be a fantastic clinician, it doesn't matter if you can or cannot do what they can do. Brett can't do half the stuff that all of his like insane level athletes can do, but he can take really great care of them.
Okay, I think that was a slight at
It
your
was a little bit of a slap, but like, right?
No,
like you don't have to be an
You're
elite level
100% right.
athlete to be able to take care of elite level athletes. You don't have to be pregnant in order to be able to take care of pregnant patients. So that's that.
That's
And now,
awesome.
if you would like to get in touch with me, if you want to come shadow me, I love having shadows at the office. It's super fun. And I'm not close to a chiropractic college, so like I'm just like begging people to come hang out. Like I have no friends. Like please come hang out with me.
Me and you both, sister.
But Triangle CRC is that is the @ for our Instagram. That is our website. That is info@Triangle CRC is where you're gonna send an email, or you can follow me at Lindsay Mumma. I'm currently not on social media because I needed to take a technology break after getting a concussion, but I'll be back on there sometime.
Nice. So we'll link that in the show notes, all those informations. And we just thank you for sitting down. You're an absolute savage. The thing that nobody knows about Lindsay is she's an amazing jester. And
I was just going to say that. We went the whole time not talking about is the MPI board. They were like, we need to grow. And then we were obviously needing another female. And I mean, the name that just kept coming up was Lindsay Mumma. How do we get her? How do we get her? And I had you as a student when you were a rep, and I mean, none of this is a surprise to me to see her success. That is for sure.
Yep, so. Definitely. So we're lucky. I can't wait to learn from you more tomorrow. We got some more stuff to cover tomorrow in the full spine class for MPI, and it's just amazing. Like I always you lay at night and think about the things that have gotten you where you are, and it's funny how MPI always is the center of pretty much everything we all do, and 100%. So it all kind of comes back full circle, and so I'm super grateful and thankful for the MPI family and the community. And so with that being said, Lindsay, thank you. Good luck on the weekend, guys, and get ready to crush patients on Monday.
Super Bowl tomorrow.
Let's go. Go Chiefs.